Hello, everyone. I'm Dr. Anderson, Director of TOVA Community Health. You are on TOVA Health TV on TOVA Tuesday. TOVA Tuesday is a TOVA Health TV platform on YouTube, and I bring on guests, community leaders, practitioners, and healers to educate my viewing audience about ways to empower themselves and live their best lives, and most importantly, build a sense of community. I'm always looking for guests and especially those that serve the community. And today I'm very excited because I have a graduate assistant at TOVA Community Health, Chloe Lassiter, who's in her Master's of Public Health Administration program at Delaware State University. And she's going to be sharing an important topic today about how to manage individuals who have acute pain with non-opioid alternatives. So before we get started, I wanted to just bring up a little bit of information about TOVA and Chloe's work at TOVA. So Chloe Lassiter, as I shared with you, is in her Master's of Public Health Administration program at Delaware State University, and she wants to concentrate in epidemiology. Chloe brings a passion and energy and strong commitment to improving community health, and she aspires to become an epidemiologist or research science specializing in infectious diseases, focusing on reducing health disparities and advancing public health equity. Chloe loves trying out different restaurants and discovering new foods. She's like me, I love that as well. And she enjoys listening to music on her free time or when it's time to unwind. So I'd like to introduce Chloe today on TOVA Tuesday. And she's going to give us a presentation, a paradigm shift, evidence to supporting non-opioid analgesia as effective acute care for pain relief. Sorry. Chloe, welcome to TOVA Tuesday.
Hi, everyone. My name is Chloe Lassiter. As Dr. Anderson said, I am a grad assistant and intern for her working at TOVA Community Health. I currently go to Delaware State University and I am studying public health with a concentration in epidemiology. So today I'll be speaking on some evidence supporting non-opioid alternatives to support pain relief and acute extremity pain. The opioid epidemic continues to be a major public health crisis here in the United States and globally by majorly the overprescribing of opioids for pain management. Acute extremity pains such as sprains, fractures, and soft tissue injuries are among most of the common ER visits. Prescribers must understand that even short-term use of opioids can lead to overuse and dependency, and in worser cases, overdoses. My paper will be evaluating how non-opioid alternatives can make an impact on safety and long-term outcomes for patients. Most of the issues regarding opioid prescribing are misleading marketing and the overuse of widespread addiction. Nearly 80,000 U.S. overdoses in 2023 were due to opioid use. Hospitals often rely on opioids for quick pain relief and to get patients out and free up beds. So opioid prescribing has relied a lot on getting patients in and out. There has also been a bias historically in the healthcare system of overprescribing opioids for white patients and the undertreatment of Black patients due to people assuming that their pain tolerance was stronger than other races. And also there were aggressive marketing by companies like Purdue Pharma that normalized opioid use and falsely marketed its benefits when in reality its long-term use can have poor health outcomes. Delaware tends to, in terms of Delaware, we have some of the highest opioid prescribing overdose rates in the U.S. 7.8 of the high dose prescriptions are due to the 100,000 people overdosing in 2021. While national prescribing declined from 46.8 to 37.5 prescriptions per 100 people in Delaware, in the US, it still ranks one of the highest overprescribing countries in the world. Opioid use has actually dropped globally about 30%, but consumption of opioids remains pretty high in wealthy nations compared to low and middle income countries. In regions like sub-Saharan Africa, limited access to opioids has led providers and healthcare workers in Africa to mostly rely on non-opioid analgesics to provide effective pain relief for their patients, which has seemed to been effective. While going over some literature reviews, I found a couple of articles and studies done on non-opioid alternatives. First, I went over a randomized clinical trial that compared opioid and non-opioid pain medications for acute extremity pain in a Bronx emergency department. They compared ibuprofen and acetaminophen to various other opioid combinations, and they showed no significant relief in the opioid options. The study concluded that while opioids can be effective, non-opioids are equally effective at treating acute pain, and suggesting that opioids are not necessary for initial pain management in the emergency room. Another study I found was a double-blind randomized clinical trial that used 53 patients and compared non-opioid combinations of ibuprofen and acetaminophen with hydrocodone and acetaminophen combinations for post-wisdom tooth extraction. It was measured at different pain levels, and it found that non-opioid combinations were actually more effective at reducing pain than the opioids for this type of pain. Post-surgical procedures should rely first line of defense on non-opioids to avoid the risk of opioids. Another study I found was a retrospective study of 101 sickle cell patients located in Jamaica at an emergency department that were getting treated for vaso-occlusive crises. They compared non-opioids like paracetamol, ibuprofen, aspirin, and effectively relieve the mild to moderate pain of the patients in the hospital. All opioids were required for severe pain, but it goes to show that for first-line defense for mild and moderate pain, opioids are not needed and can be treated with simple medications such as ibuprofen and acetaminophen. Another study I found was a randomized double-blind trial at 2 urban emergency departments. They compared acetaminophen alone versus acetaminophen in combination with oxycodone for acute musculoskeletal pain. They used 154 patients and found that pain improvement after 2 hours was actually effective with the acetaminophen alone. And the percent of the participants that used in combination with the oxycodone actually suffered from dizziness, nausea, and drowsiness, versus only 9% in the non-opioid group that experienced these side effects. The results of this study show that while opioids can enhance pain relief and effectively treat it, non-opioid alternatives should be used because they prioritize safer and reduce adverse effects to long-term harm. Lastly, I found a cohort study of 386 adults that examined short-term opioid side effects after emergency department discharge for acute pain. 79% of the opioid users reported side effects such as nausea, vomiting, dizziness, and even weakness, compared to only 38% of the non-opioid users. And constipation also was a high risk of the non-opioid users, but compared to nausea, vomiting, and all the other side effects, healthcare providers at this emergency department decided that the non-opioid alternative would be better for the patients. It shows that even short-term use of opioids carries a significant side effect, and it's needed for patient education and preventative measures such as prescribing laxatives alongside of non-opioid treatments. Overall, effective pain relief shows that non-opioid combinations like acetaminophen can manage acute extremity pain just as well or better than certain opioid medications. It can also reduce initial opioid exposure, which can limit long-term emergency care for side effects. And it also prevents patients from receiving opioids unnecessarily. There are fewer side effects using non-opioid alternatives, and that also these side effects can hinder recovery. And also, I believe there's a tailored approach that is needed for healthcare providers to treat extremity pains. Specifically in sickle cell crises, I feel as though non-opioids, while can be effective, it needs to be gauged on the pain level of certain patients. In conclusion, non-opioid alternatives can manage pain while reducing unnecessary opioid exposure in individuals. Limiting the first opioid prescriptions lowers the risk of addiction, misuse, and even overdose. And prioritizing non-opioid pain relief supports long-term public health practices and reduces opioid availability in communities. I have made a table showing certain opioid and non-opioid drugs from safest to most dangerous with their side effects of long-term and short-term use. We have some strong opioid medications such as fentanyl or oxycodone that can cause vomiting, headache, constipation, sweating, and even sedation. And then long-term use and more severe can cause respiratory depression, hypertension, seizures, anaphylaxis, and in sad cases, overdose and death. Certain non-opioid medications can cause liver toxicity as they are used long-term or kidney damage, but just for short-term, they can possibly cause stomach pain, nausea, vomiting. I have 2 pages of some references if you all wanted to do a deeper dive yourselves into the information I use for my paper. Here are some more that you can go and look at if you want to get a deeper dive into the studies I included in my literature reviews. Thank you very much. That is my paper and my presentation on non-opioid alternatives for acute extremity pain.
Thank you, Chloe. That was a fantastic presentation. And I just want to congratulate you on all of the hard work that you've done in your research project and putting this together. That was not an easy task, and you really dived deep into the literature to support that we as healthcare providers can prescribe safer regimens in treating patients with acute pain. But I wanted to have a conversation with you as well as a clinician scientist, and also Nurse Leona, who has many years of working in healthcare as well.
Mhm.
And I wanted to ask you some questions about your presentation.
Okay.
I also noticed one of the statements you made was that Delaware has had some of the highest prescribing practices of opioids that other states have in the nation. I was wondering in your research if you could provide some comments around that.
So Delaware actually was ranked number 3 in overdose deaths and overprescribing rates with opioids. It has been an ongoing issue in Delaware. There has been a lot of efforts to try to stop the rates that they're going at, such as Narcan distribution, because they know there is an ongoing issue with it. I can't give too much more data right now. I believe there is the prescription rates have went down within the last year, I believe so. But we are still at number 3 of overdose deaths in the nation. So it does need to be a problem that is solved soon.
Yes, and I would say that yes, the rates of overdose in Delaware have gone down. There's been a lot of effort around educating the community about Narcan and also changing prescriber practices and educating providers like myself who prescribe opioids on how to write or prescribe safer treatment regimens and pain plans for individuals with acute and also chronic pain. So I'm very grateful for people like you who are educating us and educating the community that as a prescriber and a clinician, we can safely provide and prescribe non-opioid alternatives, especially even as a first line. If they come in with a shoulder injury, or if they had a slip and fall, or an acute back pain flare up, we don't always have to initially prescribe an opioid. Do you have any comments, Leona?
Well, one of the questions you kind of answered when you made your statement. One of the questions I was going to challenge Chloe with was if she had any thoughts on how to address overuse of opioids, like in emergency rooms or medical settings. If there's a way, do you think there's a way that can be addressed, overuse of opioids in patients that come in for pain? Some of the information was in your, presentation, but I just wanted to ask personally how you would address that in the setting where patients come in for pain, and how to address overuse of the opioids for those who are providing the care.
Okay. So I think one of the main ways this could be addressed is through community engagement and outreach. I believe the public needs to be educated on the risk of opioid use, short-term and long-term effects. And it needs to be seen firsthand how it can affect people and cause people to maybe become addicted to it, or maybe have prescribers give background on exactly why they are prescribing and make sure they give a reason that's aside from getting patients in and out hospitals quickly or emergency departments.
Thank you for that, Chloe. I also was very intrigued, the fact that you alluded to companies providing misleading marketing to healthcare providers and people in the community that opioids were safe to use, that you could not get addicted to these medications. But we've come full circle over the last decade or so and found that not to be the case. So moving forward, just like Nurse Leona said, is that we have to change the paradigm in our prescribing practices, educating the community about the long-term harm that opioids can cause to patients. And it's not easy, as Nurse Leona alluded to, because if someone's in a lot of pain, they don't want to hear like, you're going to give me some Tylenol.
Yeah.
Or ibuprofen or whatever you're using. So how do you think as a provider we could approach that? If we have someone that says, oh, I'm really in a lot of pain. We want to acknowledge that they're in pain, but what would you tell them if you wanted to try, like as a first line, a non-opioid pain cocktail?
If I were in the position of a prescriber, I would, number one, form a level of trust with my patients so that they believe I am doing what's best for them. I'd also go down a list of short-term and long-term effects of using opioids. I know it might be the quicker treatment option and it might get rid of your pain fast, but it does come with a lot of side effects after the fact that can totally mess up your recovery process and put you back in an emergency room or put you back in a doctor's office. So I would form that level of trust with my patients so that they know I'm doing what's best for them, and also educate them on why I'm going through this route of using a non-opioid alternative and why it might be best for their health in the long run.
That's really good. And I like the way you're saying you're building trust with your patients and you're educating them. You're explaining the side effects of the medications and saying, hey, just try this first. And if this doesn't work, we have a plan B, or
Yeah.
and that kind of reassures them in knowing that you're on their side and you want them to be comfortable. But try this first.
Yeah.
Now, you know that I have spent many years taking care of children and adults with sickle cell disease, and some of the research that you have done in the studies for people that are coming in for severe sickle cell flare-ups. The non-opioid combination may not be effective in treating their pain. And that was in the study, the Jamaican study. And there was another study showing that sometimes you do have to prescribe opioids to get the pain under control. And in the sickle cell community, patients are very distrustful of the healthcare system. And there's lots of literature to show that they have been undertreated and not prescribed adequate amounts of medication and pain medications to get their pain under control. And that could lead to hospitalizations and readmission rates that are not, I would say insurance companies don't like to see people coming back in the hospital for something they already treated them for. And that also drives up healthcare costs. So for sickle cell patients, what would you recommend as a clinician for us to do? Because we want to be able to provide safe care and alternative treatment options. Would you do anything different for those who have sickle cell if they came through the ER with acute pain flare up than you would with someone that has had a fall in?
So firsthand, I can tell you that being in the office with you, Dr. Anderson, I have seen how your cocktail has worked for your sickle cell patients and how they feel an immense amount of relief, even still at the visit. And you gauge to see where their pain level has intensified or if it's been reduced. So I believe maybe doing the cocktail in combination with maybe an opioid and a non-opioid, gauging to see ultimately where the patient's pain level is first. But I would treat them with the same type of care, but just knowing your patients, you're able to better their quality of life and fix their pain levels just in one visit. So I feel like, I don't know how to say it in words. It's just seeing it firsthand and seeing how you make things so effective for your patients and how they can come into the office feeling very down and leave out feeling so much better. And then you can call them and check up on them days later, and their pain has completely subsided sometimes. So I don't know, seeing where you're at with your patients lets me know that there are options and there are alternatives for how medications can work and how it can be done patient to patient, sickle cell or no sickle cell.
Thank you for that. And I think a lot of times as healthcare providers, we think that those who live with sickle cell can't be prescribed non-opioid combination therapies. And we at TOVA have found that we can do that successfully. We can successfully treat them for acute pain flare-ups, and they can go home and be able to manage their pain. And so, as you said, you have to educate them. They have to have trust in you that you're trying to make the best decisions for them, and know that we can still give you an opioid if you need it, but we're going to try this first. And so that you're building trust, you're building relationships with your patients. And over time, then they can entrust that you, with shared decision making, that you're going to make the best decision for them and know that we can always change course if we need to. I would say that that requires a lot of time to do, time that's not reimbursable by insurance companies. But if you look at our cost and how we treat our patients long term, we may see benefits collectively. Nurse Leon, I don't want to leave you out of the conversation. Do you have any last thoughts?
One of the things I was just thinking about was just how when you have patients to come into the office for sickle cell, they might have sickle cell pain. What recommendations could be given to them? Because apparently you know how to treat them because they're your patients. You've been with them for quite some time. When they have an incident where they have to go into, like, say, emergency, and they might not feel like they're being treated fairly. What would you or fairly or properly, appropriately, I would say? What would be the recommendation to that patient when they're in the office? If there's a chance they have to go into ER, what would be the recommendation as far as pain treatment for that patient?
Well, one of the things that we do at TOVA is each patient has a personalized care plan for their overall care and for their sickle cell acute pain flare-ups. And so we provide the emergency room with recommendations of where to start, giving them a pain medication, opioid or non-opioid, to treat them for a severe or moderate sickle cell flare-up. And so having that documented in writing and also to have it integrated into their electronic health record is reassuring that, hey, this works for them. I try to tell the emergency room is seeing patients for so many different ailments and illnesses, from gunshot wounds down to feeding somebody that comes in for a sickle cell pain flare up. And that could be critical if you don't aggressively treat the patient effectively with the proper dose of medication. So our goal is to stabilize them, hydrate them, and let them be able to go home to manage their pain. And so we're on your side because we want them to go home if they're able, and we want to get their pain down and relieved. So having that personalized care plan is important. It validates that they do have sickle cell, they are under care, and we're trying to help them and tell them what dose recommendation works for the patient. Every patient is different. And so I can't say all the times we don't run into problems with the doctors or those who are treating them, but it gives them a sense of relief knowing that, hey, we're doing our part to help you have the best experience when you're going to the emergency room. And that validates that, hey, they're going to be taken care of when we do want them to get the best care that they can, so that they can go home. Well, one last question. Do you think, because I'm coming in, I've been in the healthcare space for over 20 years. What would you like to see us as clinicians and healthcare providers that treat individuals with acute pain, but also chronic pain? How would you like us to treat them in the most compassionate way, so that we can prevent those long-term unintended outcomes for those who have misused opioids or have substance use disorders attributed to being overprescribed opioids? I've close to another 10 years to my career, probably ending, but you're just starting out. What would you like the system to look like?
I wouldn't say you, but overall in the healthcare realm, I think that more providers should take time with their patients. And when I say take time, I mean get to know your patients. Don't just be in a rush to send them out. I've seen, since I've started working here, a lot of patients and individuals say that other offices are just quick to not get to know their patients, give them the quickest form of treatment, and send them home instead of actually getting to know where your patient is at. Same way you said, personalize the patient. make everything personalized to them, their treatment plans, everything you know about the patient. And that's how overall you'll be able to treat them. But that does take time. It takes getting to know your patients. It takes getting to know patients' families, outreach, getting into the community. I think it takes time. And I think you are a great example of how, if you take time with patients, you can effectively treat them in and out of the healthcare field.
Thank you for that, Chloe. I'm going to make you the health ambassador for TOVA now. You got a job. Well, this was a great presentation, and I'm so grateful for all of the work that you do for TOVA. And I've heard you have learned a lot during your internship, and we definitely wish you all the best as you continue on your journey. And whatever you do, you're going to do great. I'm very confident in that as well.
Thank you.
So I just want to thank you all for joining us today on TOVA Health TV, TOVA Tuesday, where we had our special guest here, Chloe Lassiter. To learn more about TOVA Community Health, please visit our website at www.tovacommunityhealth.org. Please be sure to like us on Facebook and Instagram. And if you feel so impelled, please make a donation to TOVA so we can continue our work and also support our paid internship program here. We are a small organization who makes a great impact in our community. Thank you for this great presentation on effective pain management.